We'll get going as it's 8:30, and hopefully people will continue to trickle in. Um, my name is Sienna Pender, and I work at Archbold, and this is our July Level 3, Level 4 committee meeting for the Georgia Trauma Commission. All of the minutes from the May 22nd meeting have been sent out. And so, if you haven't done so already, please take a minute to review those, and we will entertain anything that needs to be changed or a motion to approve as written.
I'll make a motion.
Got a motion to approve the minutes as written. Do I have a second?
This is Rachel Hand. I'll second.
Thank you so much. We've got a second. All those in favor of approving the minutes as written, please say aye.
Aye.
Anybody opposed? All right, great. The minutes are approved as written. We can move on. Liz, are you on yet? I know she's logging on, but switching over to her laptop. We could go ahead and we could go to our old business on the rural interactive trauma simulation course update.
Sure, I'm here. Can you guys hear me?
Yeah.
So the pilot year went really well. Basically the first year was going through, we did 12 deliveries of the course, had overwhelmingly positive feedback from everyone. Moving forward, we've already scheduled multiple courses through the fall and into the spring. What we're trying to do now is we're actually going to one location and doing back-to-back courses, but also getting a larger spread of rural counties and areas surrounding those areas. So we're doing Northeast Georgia Health System in August. I believe it's August 12th and 13th. And we're going to be drawing from a number of surrounding areas and really capturing a lot of those smaller hospitals, utilizing the regional hubs and those resources and RTAC coordinators. In September, we are going to be in Thomasville. So we'll be tackling that region that we haven't been to yet and capturing a number of places in those surrounding areas. And then we are in Hinesville, Savannah in December for back-to-back courses. And then we have 2 more courses scheduled in March. And that's going to be in the Rome, Dalton region. So at this point, we still need to schedule a couple more places for the spring. And what we're really doing is working with the local facilities, but also the RTAC coordinators to make sure that we're capturing and we're including these smaller regions. So, and not only that, but we're also, now that we're going to some of these kind of like regional places, we're going to be trying to include instructors that they have there, whether it's nursing educators, EMS educators, other ER, emergency medicine, or surgery educators that are interested in potentially doing the course and helping not only facilitate some of the simulation component, but also trying to get people on board and exposure to the course that may be people that would want to do that course in their region, so that eventually the plan is to have sustainability and the ability for the different areas and regions to be able to do the course without it just being Dr. Mabe's going everywhere. So everything's going really well. We did get a little bit of funding from Emmanuel to help replenish some of our supplies. And then aside from that, I'm just waiting on the Georgia Trauma Commission for finalizing the grant for the program this year in the fellowship. We do have a new fellow. He's on, he's jumped right in. He's learning the ropes, and he'll be traveling around with me this year again.
Man, so wonderful. What fan work for the program. Just a testament to how good it is.
Yeah, it's been a lot of fun. It's well received, and so we're hoping that over the next couple of years, we just move forward with growth, getting more education leaders on board, and then able to really make it sustainable.
And that's so great. Thank you so much for all your hard work.
Absolutely. Thank you guys. And if you guys have locations or people or connections, please feel free to reach out with me so we can continue making those connections and have conference calls and get the final courses scheduled for the spring.
Great. Great, great, great. Okay. Liz, we got you yet?
Yes, ma'am. Kelly, I'll go ahead and share my screen. So if you want to kind of walk through these.
Yeah, I didn't know if you wanted to do an update first, Liz, or if you just want to go straight into this. Do you want to?
Okay. Yeah, sure. Go ahead. Start with that and I'll pull it up.
No, I meant an update like for the commission.
Oh, sorry. I'm too busy multitasking here. Yeah, not too much to update the group on today. Obviously, everybody knows our big meeting is coming up in August, the commission meeting combined with GQuIP as well. There'll be an administrators committee meeting after the commission meeting. So I believe all the registration deadlines are either right now or Gabby has more information on that, but I do know that the hotel block has been long sold out. So if you don't have your hotel already booked, you're definitely going to need to look at one of the overflow hotels. So more information has been, a lot of information has been pushed out. So just reach out directly if you need more information on that. The other big thing is that what we'll talk about in a minute is that we are looking at how can we do sort of a wholesale reevaluation of the funding distribution. This came up sort of on the last call. So some of you who've been around for quite a bit of time might remember Greg Bishop, Greg Bishop is sort of one of the startup partners of what ultimately ended up becoming Trauma Center Association of America. But Greg has a separate consulting business that really focuses on trauma systems, which is, pretty rare for someone to focus on trauma systems specifically. But he was kind of the author of our original funding distributions. And as you guys know, things have changed over quite a bit of time. So given that we wanted to look at how funds are distributed specifically to level 3s and 4s, we're have re-engaged with him, and the finance committee on Monday afternoon will take up a proposal by him. I don't think the proposal probably still needs a little bit of work. Kelly, thank you so much for your help. And because you've been around and you've had some familiarity with this since the beginning. So as one of the founding commission members of the original appointees. So it's been really helpful to have that context and your experience in kind of looking over this and what it needs to look like in the future. So I think what will end up happening is they'll just approve a placeholder for the funds. We'll continue to work back and forth on the scope of work for that project. And then it will ultimately come forward to the commission for August for approval. But it's exciting because it does allow us, sorry, I'm competing with a leaf blower here, so I hope it's not too much additional noise in the background. So hopefully we'll get over that hurdle, and it'll be really exciting to see, and there'll be a work group that will be assembled. Dr. Ashley will appoint it, and we've identified a few members basically from each level of center, just because while we're looking at the funding formulas in general, it's good to have representatives from all levels and trauma program managers, surgeon leaders, administrators, et cetera, system type people. So, so more to come on that. So that's really exciting. And I think that was about it for my update, Kelly. And I think that's probably a good entryway into our
Liz, you still wanted to address the ACS level 3 verification deadlines that are coming up and then committee membership, or do you want to address that after?
yeah, let's do that after. Let's do that after.
All right, so I guess I'm gonna try to share my screen. Because Liz and I talked earlier this week, and I don't know how many people remember this from last year. It's been a year since we've done this survey. And from this survey, and I was thinking about our meeting in May and how the focus still needs to be on the things that we found to be important. So this was what Liz and I met about on Wednesday, was this survey plus, and Liz, I don't know if you want to pull up, well, let me just say this first. You can see here the priority items that we had a year ago. Trauma care practices, transfers, trauma-specific protocols, education, and financial stability. And then Liz, if you can share now where we pulled up what ACS, when they did the system visit and they came and identified and made recommendations for us, we mapped those out and looked at the similarities and how much we've done since 2023. So I just wanted to kind of connect the dots between these two, and let's determine, where do we go from here? Like, what are our next steps? What do we feel like is the most important, or kind of we're making some progress on, and therefore let's kind of keep these going. And then what needs to be our primary focus? Because I feel like I want a committee or group that's going to be working, and I hate for us to just meet every month and or every quarter and not feel like we're taking some action. So with that being said, in this rural focused recommendations, the first one was the resource needs assessment that was done. The first one was done with all hospitals in 2022. Then we had this survey that you just saw from 2025. So we've accomplished that in the last several years by identifying what's important. There were a lot of things on recruitment and retention, and that's focused on rural providers, nursing, and EMS. As y'all know, Crystal has done a fabulous job with the new EMS education rollout budget program. We also have Dr. Mabes and Augusta's new RITS simulation course, which I think is also meeting that deliverable. And I think over time we'll see change. It's not, we're already hearing very positive things, but I think the more we build that and the more it's dispersed throughout the state, the better that's going to be. The second one was rural trauma hospital participation in EMS in an inclusive Georgia statewide trauma system plan. We've kind of tabled that one for now because it involves so many players that it's going to take a lot of time to develop. Qualifications and educational requirements for providers caring for injured patients in the rural environment. That number 3, it's very difficult as a commission or even as a committee. I'm not sure what ability we have to impact educational requirements for providers in our state. And if anybody,
Kelly, the one thing I thought about after we did this is that the only thing we could do is put out some kind of like white paper about like what the evidence is. Dr. Mabes has some wonderful data from her program. And then there is, there are some papers out there. We could develop a white paper,
Yeah,
Okay.
this is Damien. I was going to weigh in on that and say something very similar. Whereas we may not have the ability to say requirements, we could have maybe a position statement that states these are the best practices if you have these qualifications in your ER.
Hey, Damien, who would that go to GHA or how would you do that?
Ah, I mean, you mean to distribute?
Yes.
Yeah, I think GHA would be a good one to distribute that.
The rural group, Damien, would that be a good outlet for that?
Yeah, so I think it would, but I understand the hesitation to try to be part of dictating what providers do. In fact, impossibility of it, but stating um what this group knows of as best practice would be really, really helpful.
And we'd be happy to help with drafting and writing a paper as well. We've already put together some papers and we have our data, but just to be able to contribute, I could, and my new fellow, I mean, scholarly activity is part of the fellowship, so we're happy to help out as well.
Oh, yes, let's tap into that scholarly activity. It's almost like a bucket of other duties as assigned.
Yes. And greatly appreciated from the level 3, 4 group perspective.
Definitely. And I would think, like, let's say if a rural hospital looks at it and there's a gap, there's a differential between what they are and what is recommended, then that gives them not only something to work for, but also that's perfect for grant opportunities because then they can say, this is where we are. This is what the gold standard is. And can we apply for some funding to help us get there? I think it could be really, really helpful for them.
Great. Great. Um, all right. So Dr. Mabes, I'll touch base with you at some point about that and how we can move forward with that. The next one is the mentorship program and just the basically connection, honestly, between the rural trauma facilities. And so Rachel Hand has the Trauma Connections group, which has become quite an amazing resource sharing group um, that talks a little bit about any challenges in the rural community among trauma centers. And I think, Rachel, you're going to report out later just specifically on like what we've done lately, but that group, if you're not involved in that group and you're a rural trauma center, I highly recommend reach out to Rachel Hand, get involved there because the resources and the information that you can gain and connections you can make, um, they're they're more than you could ever imagine. Number 5 is the statewide RTAC system. We do have all 10 RTACs. They're now active. They're working through programs and they're developing their RTACs. So I think that we're making progress there. Some, of course, are stronger than others, but at least now we all have RTAC coordinators and we're all building. The funding was one of the major priorities and it was brought up in the last meeting. And I am excited to see where we go with this engagement with Greg Bishop, but at least there's some movement there and we can look through as 3s and 4s how we can stabilize our system and our centers. So 6 and 7 are both kind of funding and future funds and all of that as we move forward with Bishop, we'll see where we are there. And if you want to scroll down, Liz.
When for those that like I know we're talking about anyways, I would offer like a simple sentence that the whole purpose of this thing with Greg Bishop and what Liz and Kelly are talking about is we think that instead of using the current parameters to try to demonstrate the funding needed for threes and fours, that we need to redraw the parameters and look for a novel approach to let the state know exactly how our resource needs are different than maybe ones and twos. Because comparing us to them or using their formulas seems to be restrictive for us in describing our needs. So that's what all of this is for and about. I didn't know if that was obvious or not, but that is the genius of Kelly and Liz.
Hey, everybody. Thank you for your efforts on that. A quick question. It says engagement with BNA. What is BNA?
Yeah, that's what, great question, Damien. That's what, I mentioned a bit, Greg Bishop, that's the name of
Greg,
it.
okay.
Yeah, it's
That's his
Bishop.
consulting firm.
Yeah, it's Bishop and Associates. Yeah. Mhm.
That was just a missing piece. I'm on track now.
Yeah, no worries. No problem.
The last part is this trauma system components and integration. And so you can see this aligns fairly well with the priorities that we established last year through the survey, standardizing trauma care, and then improving the abilities to manage injured patients, developing the process for rescue stops and accelerated transfers. There is some discussion here about telemedicine. So those first several things, we're hoping that as the RITS course, and Dr. Mapes, hate to throw you under the bus, but we're hoping that as this evolves and it's being taught different places, insight is also being gained that would be invaluable as we try to determine our different regions have different needs and how do we best standardize protocols. Is it going to be by region? Is it going to be by center? Is it by level? Like what is, I mean, to me, y'all are the key. Go into all the different areas. And so you can identify strengths and weaknesses based on just your interactions with those centers, that you get the whole picture. So then you can kind of help provide guidance to the group, because, I hate to, from me, my perspective in Southwest Georgia may be completely different than Damien's perspective where he is. And the issues are still major issues, but they're so different. Or maybe they're the same. We don't know. And so I think having you travel like you are is going to provide insight that will help us from a state's perspective.
Well, I think you bring up a good point, and one of the things that we had discussed, like kind of having like a baseline instructor manual, but also having the ability to kind of flex with special patient populations for certain areas. So, what we see is, some places I go, they're like, we have a ton of obstetrical trauma. We really need to learn about obstetrical trauma. Or, when I was in Hinesville, they're like, we have one of the highest pediatric trauma populations. And, we really need more information on how to stabilize pediatric patients. Obviously, elderly populations are another one, but one of the locations also is like, we have a really high amount of penetrating trauma. Can we go through different penetrating trauma scenarios? So, and we've talked about this a little before, there's probably somewhat of a combination of you guys have a tremendous amount of data that you collect. And so looking at it on a much more kind of granular level to see what are those needs there, what issues are you guys seeing? I don't have access to that data. I think that's mostly like the GQIP and the registry data that you guys have. So I would lean heavily on y'all for that. But I think, moving forward, if you can take not only what different places are saying they need, but could have almost like, here's 10 additional scenarios and hot topics to focus on. What are the most important to your group before coming, so that you could have that as an additional bonus focus. But then if you guys have specific areas that you're seeing there is a need based on the data trying to include that in course deliveries in the future.
Okay. I think I'm moving on down. Liz, number 4, wait, the telemedicine, I'm going to back up and just address some of the things we talked about. Number 5 was talking about telemedicine capabilities. And so again, we've got things coded red, orange, and green, of course. Green being things we were addressing, red, we're not really sure how to address. And then the orange are kind of up for discussion. We're not really sure, except for number 7, which was the develop an interfacility transfer system sensitive to the challenges of rural care. This is a wish list for all of us. Hopefully, maybe with the RMOC talk and discussion, there could be something that comes of this, but that's not a 6-month attainable goal, I don't think. Telemedicine, Liz and I talked a little bit about looking at the transfers that maybe are discharged from the emergency departments of the higher level trauma centers. And do we identify a certain injury and maybe start like they do stroke? It's all stroke. Do we take something like an orthopedic injury and develop some sort of model for telemedicine for level 3s or level 4s to consult with a 1 or 2, have a determination, and have the patient be sent home to follow up with whoever, in a day or 2, or do we develop some sort of plan there? And I don't know the answer to that. I welcome any discussion on that, but is that a possibility?
Hey, Kelly, this is Jay down at Piedmont Henry. We may be able to add some to that. We've just went live in the last 2 weeks with Grady, specifically around oral maxillofacial, ophthalmology, and burn, because we did find that we were sending so many to them only to be put back in a car to send back to Henry County, Butts County, all the way down as far as LaGrange. So in the next several months, we may have some data. We've opened it up to ophthalmology and burn currently. So we get feedback from our experts in those fields where we can avoid transfers, which again avoids all the intra-hospital transfer delays that we have for taking people down there is one of the focus points we're looking at as well. But then also keeping patients from having to ride all the way down to Grady only to turn around and come right back home with a referral to come back in a week for their surgeries. We expect to expand to oral maxillofacial opinions very soon. We've just completed this week the Epic integration so that we can see their notes in the chart. That was one of the big pushbacks from ER providers, were that they wanted something in writing. So Dr. Walker's group's now been able to put through Care Everywhere recommendations into the chart. And our whole goal is to avoid unneeded transfers and unneeded burden on the interhospital transfer process, since we know it's already overburdened. So in the very near future, we should be able to provide some information to that.
Great.
Hey, Kelly, it's Gina. And y'all are going to hear at the GQuip meeting where our scholar that just rolled off, Hillary Jessup, started some work analyzing the non-therapeutic transfers from the pediatric population. So that's going to expand, and they're going to work with the pediatric surgeons to really dive into that. So we at least have done the data dive from a research perspective to look at that population, because the pediatric facilities have long said they get tons of kids that they transfer in and then discharge. That's been a huge issue for the pediatric. So we are working on that within GQuip on the pediatric side. So we'll have data on that as well.
Thank you.
For the services, just a quick thought that like OMFS, they transfer them and they get an outpatient referral for a week. Is one of the things, is it trackable to see what percentage of patients actually make those follow-up appointments and identify barriers of care there?
Yeah, so this Jay again. So that's one of our also hopes because they actually, when we call to Grady, Walker's group is in creating basically a patient chart so we can follow to see, are they following up? We asked him for some data last week just on the number of patients we've already affected. All of our ER physicians that were in our meeting had spoke to, they've already used the process once. So we want to find a way to quantify it on our side, but then more importantly, quantify the follow-up on that as well.
Outstanding.
All right.
I'm really glad to hear this. This is a pretty big problem that Emmanuel has as well. And then unfortunately, because of just the limitations in EMS resources, we're running our crews almost nonstop. And I will hear anecdotally about somebody sent to a level 1 that gets discharged an hour later. That's pretty challenging for us. And so, Jay, I look forward to hearing what you're able to put together there.
Yep, we're excited. We'll keep you posted.
That may be a good winter GQuip presentation, Gina. Just as a thought.
Keep that in mind.
Sorry to throw you under the bus.
No, that's
Dave,
okay.
but both of you, I mean, Jay having to talk and anyway, but I think this is what we need. And then we go into the maintain accountability and designation and redesignation of level 4 trauma centers. I think we have the PTSF consults, which that's on the list to talk about a little bit. I think that's on the agenda. And the state designations are ongoing.
Sorry.
No, you're fine. And then I'm not sure. I think number 10, the innovative programs on a local level to fulfill staffing shortages is more of a Christmas list too, because I'm not really sure how we can address that. I can't. Obviously, we left it blank, Liz, because we were stumped. Repatriating patients to their local facility as appropriate.
I think that ties back to the try to keep them from getting out anyway, right?
Right. And then the air utilization, depending on where you are in the state, that can be a challenge just because of weather and how that works. So after she does that, we'll move on down to the data and performance improvement. We have made a lot of movement here with all of these different initiatives. You can see GQuip and Qcentrics have been extremely helpful with data entry and validity, education and collaboration. I will say too, like from the Trauma Connections group, Rachel's done a really great job of having different people demonstrate how they capture things and what they do from a performance improvement perspective using the registry. So that's been extremely helpful. We've also had several different courses related to performance improvement. There's a course in August that's talking more about trauma center management and just the bigger scope of the program. We have rural topic in 2027, which is PI, catered more towards the rural centers. So that will be coming. And then the RTAC Regional PI Collaborative. So Gina has started, if you're part of your RTAC, you should be seeing your GQuip RTAC dashboard. And it's been really helpful for us. It shows our region, it shows all the other regions so we can see how we compare to others and really identify what we need to do moving forward, or maybe what region we can reach out to say, okay, how do you handle this, or what are you doing differently? If you're not getting that, I guess reach out to Gina or your RTAC coordinator.
Yes, your RTAC coordinator, because they get them.
Okay. And then we have let's say develop a program to assist rural facilities in the management of data acquisition. There is the GQuIP mentorship that's going on. Dr. A. Young Chi and Gina will meet with anybody anytime and go through when you're struggling with your data. And if you have not utilized them, I highly recommend it because they are able to take something that may seem very confusing and translate it into a way that helps you understand. And that way you can take what your problems or things that you're finding and address them. Because once you understand, it just takes time to understand data, or maybe some people are not data driven. And so they are able to put it in a format that you can then understand and move forward. And we also, again, are praising the Trauma Connections group on the data and PI. So between the survey and this ACS system recommendation, I do want us to see that we've made some progress and we continue to make progress, but of course there's always things to be done. So in the review of this, now I feel like between the funding initiative, the white paper, and then this this possible telemedicine connection, we've got a few things now that we can start really working towards for our next meeting to talk through. Are there other things, or is there anything I missed that we need to think about moving forward?
Do you want to go ahead and talk about the Pennsylvania group coming back?
Yeah, Liz, do you want to go back, or Gabby, whoever's got the screen, go back to the agenda?
Oh, I'll stop sharing.
Yeah, it's the action planning PTSF consult visit. Liz, they've reached out to us, right?
Yeah, and we have a meeting set up with the leadership of this group to sort of talk through. We do have some new level 4s in the system who would benefit from the initial consult, but I think the goal today was to talk through some centers have had them twice already. I know that was really helpful. And is there, and I think second round for some people was more of a PI focused review. So we wanted to talk through just so we can get a better idea, because if we do move forward with having them do full consults on the 2 new level 4s, if there's interest in having if anybody's interested in having them come do more of a deep dive on PI or whatever you want, now's the time to speak up, because we'd have to include that in the scope of work, and there'd be pricing options along with that. Overall, I would say for what they do and coming on site with you, it's probably one of the biggest bang for the buck in terms of money wise. So you guys were here and open to feedback and what you think you might want.
Well, and when we have the phone call with them in August, which we can report back on this, I guess, when we meet again, is just what else they have to offer, or what coming again would benefit us is what we wanted to ask them, right?
Yeah, and what would, if folks do have a need for something specific, like I see somebody put in the can you talk a little more about what this consult is? We're a new level 4 and don't know anything about this. Okay.
Yeah, Christy's from Colquitt.
Okay.
Liz.
So, and some of the level 3s might not even know because you guys didn't get the benefit of this, but Pennsylvania has a pretty mature system and data repository. They've published quite a bit. They have their own, they don't use ACS for verification. They have their own statewide accreditation. They have additional standards on top of the ACS standards that they hold the centers to. So it's known nationally for being a pretty high outcomes system. Their TQuip collaborative report, I will tell you, looks amazing. So all the centers together collectively, it looks really good. So anyway, we had them come, and they have quite a bit of level 4s proliferated across Pennsylvania. They're about the same geographic square miles, if you will, as Georgia, just oriented a little bit different. But they do have quite a few level 4s. They have some long-standing level 4s, very high-performing level 4s, and they have shared all of their resources. They got one of their level 4s to share their practice management guidelines, which I think a lot of people found helpful, just because the stuff that happens in the 1s, 2s, and 3s is not going to be applicable in level 4. So, so they came and did a consult visit, which is similar to, and Christy, you and I can have an offline conversation if you would like. Please feel free to reach out to me. I'm happy to schedule some time on my calendar, but because the level 4s don't have an ACS process and state designation is a little bit different, the ACS actually does a full consultative process whereby they come to your center and they do a similar survey. They do the consults in person again now. They're switching back over. They're even doing first verifications in person, but the consult visit is kind of almost like a mock review, but it's really designed to kind of find where the strengths and weaknesses are, because they want to kind of help you figure out how to position your center best in order to be successful with an actual real site visit. So, and I think the Pennsylvania folks, they even created a pre-review questionnaire folks had to fill out so they could have some sense of what your center was like before they got there, and be able to best help and support you. So that's a piece of it too. Usually that's about 60 to 90 days out, and you give them some information about your center. So for the couple centers that are new, perhaps we'll have a little bit of we'll have a call with you guys just to kind of talk about what this looks like. But I think all the feedback from that process was so tremendous. And so now it's about, if somebody wants them to come and you just want to spend the day going over things you want to do, that's fine too. We just kind of need to understand what kinds of things you want them to look at. And then, as Dr. Pender said, we can talk with them. Once we kind of know what the needs are, then we can talk with them about creating something that works from a scope sort of perspective. So we can make sure that we get you what you need. So Christy, I hope that answered your question, but if not, feel free to reach out to me directly.
So, I guess as centers are considering if they want to use this resource or not, who should they be in contact with about their needs?
That'd be me, Dr. Pender. That's fine.
Okay.
Yeah.
And then more to come on that as we see what everybody needs and wants, and then hear from their side too. We don't want to pay for it just to simply do it, but it is a tremendous resource. And I may be speaking out of turn, but I think Pennsylvania's trauma system is the best of the best in the country as far as integrated care goes. I mean, it's what we would all like to be.
And as we're wrapping up the meeting here, please feel free to put comments into. I'm watching the chat. So if you're thinking about things that you want help with, just pop it in the chat.
All right. Trauma Connections group update.
Hi, everybody. It's Rachel. Can you hear me?
Yes.
All right. Bear with me. My voice is kind of coming and going. I'm fighting off this little summer cold, if you will. Kelly has already kind of alluded to a lot of the things that we've been working on throughout our last couple of meetings. Again, this is a really informal. It's a 30-minute meeting that we have scheduled on the calendar every month for any of the interested trauma program managers or PI staff or registrars from the 3s and 4s. Again, the goal of it is to build those relationships and the mentorship between centers, allow the new TPMs to come in and have that network kind of at their ready if they're in need of anything. It's a safe space where people can come and bring their questions, bring their issues that they're running into, that type of thing. And it has really kind of taken off, like Kelly alluded to earlier. So thank you to everybody for all of your participation, and it's great. I certainly cannot take credit for this. It's definitely a group effort. Some of the most recent things that we've been talking about, we have a lot of discussion on PI. Like, we know that this is a thing that everybody tends to struggle with. So some of our recent conversations related to around people's like comfort levels when it comes to tracking PI data, presenting their data, gathering it in a way on, let's say, a PowerPoint slide or an Excel document in order to let it make sense and for it to really show what the TPMs are wanting their data to show. TPMs tend to spend a lot of time in data. We know this. We have so much of it, and sometimes it's hard to kind of pick out the really high level important things and make our data show what we want it to show. So again, this is something that a lot of people struggle with. What we did most of our during our recent meeting was that we did have a little bit of discussion around that. And my game plan for our next meeting is to bring in some of the tools that I picked up this time on the topic class that was recently offered through the commission. It was a great class for anyone who was able to attend. If you have not attended a topic class for the TPMs or PI people, I highly suggest that when this rural one comes around next year, that you hop on it. It's a great class. It's a great resource. And I've taken topic like 2 times now, maybe even 3. And I've taken both the topic and the rural topic, and I get something new out of it every single time. So please, 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 if you have not taken it, be on the lookout for that when it comes out so you can sign up. But some of the tools that I got from this recent one, I'm going to bring to our next Trauma Connections group so I can share it with the group. We had a PI demo from one of our participants. What she did was she logged into V5 in the outcomes module and actually walked us through how, like, she made a fictitious patient in the registry, but walked through how she would find comorbidities and complications, and once identified, how she runs through the whole PIPS process with it, and how she documents everything, how she documents her minutes, how she documents her various meetings and education that's provided by the staff or action items that are identified. And that was very helpful to see someone's actual use of it, because what we determined is that some people are utilizing a different tab in the outcomes module, and they're basically documenting information in multiple tabs, where she was able to document everything in one. And it was good to see that, because not a lot of people understand this outcomes module because of a lack of like formal training on it, if you will. And so being able to see someone's actual utilization of it, I think, was a big, big help for everybody. We had a lot of discussions about possibly bringing in the members of the PI committee. So Raymond and Ashley, we're going to be reaching out to y'all, and we're probably going to be pulling in or making requests to see if anyone has certain topics that they're willing to share with us, like with the Trauma Connections group, and actually demo either like some PI slides that you've created and how you show your data, or maybe even how you enter it into the registry. So just be on the lookout. We're going to be asking soon. So it's coming. We had a lot of recent discussion related to consistency of chart reviews when it comes to like complications, comorbidities, and mortalities. And we had some discussion that involved the benefits of bringing in some outside perspectives. So I know Kelly already talked about Dr. Aon Shi and Gina's wonderful work with the data and the Arbormetrics data. They are amazing when it comes to data. So I just want to reiterate it. If you have any questions about your data, make sure to reach out to them. They're always so helpful when it comes to things like that. And like Kelly said, they make the complex data make sense. They have that unique ability to make it, just to break it down and to put it into a format that really is understandable for everybody. And they can probably get you to the point where you're more comfortable presenting your data in a way that makes sense to everybody else and making it show what you want it to show. So those are definite benefits. So the benefits of bringing in that outside perspective is just, it speaks volumes, and can have a humongous impact on everybody. We had a couple of folks who did share some tools related to chart reviews and mortality reviews. So kudos to them. Thank you. What we want to do is, again, have this group to be able to share those resources. And so one of the ones that we were able to share was like a mortality review document that breaks down how to review your mortalities. So that was very beneficial. You know who you are who shared it. I'm not calling you out, but thank you. And complication reviews. So if there were any type of events that were identified, somebody was able to share a tool that broke down, for each element that was identified, about 5 or 6 questions that were standard as to what to ask on those whenever you were diving into the reviews on those records. And I think that those tools are very helpful, especially for the level 4 TPMs. Myself, I am a level 4 TPM, and I just know that, sometimes you don't know what you don't know. And you might think that you're reviewing something in its entirety, but then someone offers that outside perspective and you're like, oh, there is a better way to do this. So I love the fact that this group is bringing all of these resources together and creating that safe space for people to come and chat. We actually did have Dr. Ayan Chi come and present. She talked about the Arbor-Metrics data in one of our recent meetings. So I'm sorry if you missed that. It was great. But lots of things coming out of this group. So I'm excited to see where it goes in the future. That's all I got.
Thank you very, very much. It is exciting, and it is an excellent space and resource for everybody. I'm just sitting here feeling a little bad. I maybe we will look for a way to make these meetings more interactive in the future and not just slamming everybody with data and projects. And there's just so much going on. We're already just about at an hour and we don't want to keep you any longer than that, but there's so much to do and be done and going on, and everybody's working so hard. It's just great. We'll wrap it up with committee priorities. Clearly that encompasses everything we've talked about so far today, but if anybody has anything else they want to talk about quickly, in contact with Liz or Kelly or myself so that we can bring it to the forefront of the discussion.
We do have a couple other things we gotta visit today real quick, Dr.
Okay,
Pender.
sorry.
Yeah, no, you're good. One is the committee membership. This should be easy. I think it's hard to keep up with distribution lists, but if nobody minds, we're happy to send the invites to for those of you who've got PI coordinators or registry folks or whatever. I think if unless I'm mistaken, everybody at a level 3 or 4, anybody's welcome at these meetings are open to the public as technically as government meetings. So do you guys have any does anybody on the group have any issue with registry or PI folks being in attendance on this? Or Dr. Pender, I should say, do you see any reason to not have those folks present?
No, I think all are welcome in these discussions.
Okay, great. We can close that item then. We'll include that on there.
What about prospective level 3 and 4 centers? Would it be appropriate?
Yeah, I think it's great. I think it's fine.
Okay, perfect. I will send the updated calendar invite to everybody to include those additional people.
Get them in the loop. And then because I know a lot of questions come up for people who are new, and we're happy to take the time so we don't have to take the time out of the call time to go up, to go over some things that new centers might not be familiar with. So, and we have Gabby has orientation calls with those centers as well. So, and then the ACS level 3 verification deadline check-in, because that's coming up really quick. So if this group wanted to make any recommendations about that, There may be one center that might not quite meet it. And the way you guys will notice for level 3 centers in your contracts, we've now constructed them the way that the level 1s and 2s are, because if you're not verified or you receive a letter of no verification before July 1 of the current fiscal year, you don't get funded for the following fiscal year. So any level 3 not being ACS verified before July 1, the way that the commission voted and the way that it was brought, the deadline was June 30th, 2027, to be funded for fiscal year 28. I can't believe we're talking about 2028 already. But anyway, but that's the way it's set up. So I have a little bit of a handle on where people are, because the ACS does include me in your communications about your consult visits, but this is something that we'll have to, we don't necessarily this might require a little bit more discussion than what we have time for today. I was hoping we could land the plane and then bring it to the commission for August. We still have a little bit more time. We'll be in core deal for the November meeting. We will have a meeting of this group, but I believe it's after the commission meeting. So we'd probably have to have another called meeting to talk about it again. So that's kind of what we need to decide. You guys tell me what direction you want to do, if we want to try to have a separate meeting to make this a little bit more intentional.
What is the time frame after an ACS visit to correct deficiencies?
So they typically say you need about a year to get, and from their timing perspective, just from a scheduling perspective, even if you had a visit, let's say in February, and then it takes them usually 60, even up to 90 days to get your report back, you would be looking at a 15-month lead time to schedule a verification site visit. So it's not a quick turnaround, even if you want it to be. Even if you say, okay, we're going to turn around and schedule a verification, in some of the busier times, it can take as many as 15 months. So, my,
I don't.
Go ahead.
Sorry, I was just going to say, I don't know what the previous discussion has been on this, but I suspect that there should be some flex built in to allow for a center that has their visit to correct their deficiencies before losing funding.
Yeah, the way that the deficiencies are corrected essentially is if they get so what you're saying is yes, basically, to allow time for the visit to
Yes.
for the official verification. Yeah. In order to do that, I would say, looking at the timeline, Kelly, do you remember what you and I talked about? I almost think that you have to stretch it out because of the way the new contract language is. I almost think you have to stretch it out to July 30th, or excuse me, June 30th, 2028. Is that what we talked about yesterday?
Yes, that is what we talked about.
Yeah. Which is essentially just another 12 months.
Mm-hmm.
And then if you feel like you can't make that deadline, I think please reach out to me. But if you're in one of this gray area, you have to know you can't wait on scheduling the ACS. You have to get on it quickly. They fill up very quickly. And, given all the people you're trying to juggle with your C-suite leaders and for ACS to get surveyors, sometimes the times it's really hard to get everybody's time that jives together. So please keep that in mind when you're scheduling or when you get your consult done, because I know some of you are still going through consult. It's going to require that you turn right back around and get and I believe Gabby, I've been sending along all the communications from ACS. So if you do fall in this gray zone, I'll reach out to you. We'll figure out what a plan is that you're gonna do post-consult. And then we'll make the recommendation to this group and this group can make the recommendation. The reason we're talking about it now is because I don't want it to get down to June 30th and you guys are, and the group is making a recommendation to move it forward. So we just need to get it done as quickly as we can. So so there's enough lead time. So we can bring it back, Dr. Pender.
Okay, I think that's good because whatever we do, we want to give everybody the best chance to succeed.
Right.
Agreed. It shouldn't feel punitive, like, oh, you couldn't get across the finish line, so you didn't. I mean, on some level, there has to be some standard that everybody is achieving, right? And that's why those standards are set forth. But at the end of the day, it's not meant to, because overall the goal here is really to improve care. So we want to work with you, but if you're, let me say this, if you're one of the centers that is not going to have your verification in hand based on your visit cycle, not necessarily nobody has a crystal ball. So I know nobody can tell what the outcome of your visit's going to be, but let's stay positive. If you don't have a verification visit scheduled before, June 30th, please reach out directly to me and let's figure out what your plan is going to be. And then that can drive what the committee brings forward as a recommendation if we need to. Sound good?
That sounds great.
Thank you. And only 2 minutes over.
Yeah, I think we
All
have
right,
the
anybody else
priorities.
have anything?
Dr. Pender, the last thing was the level 3-4 committee priorities, which I think we addressed earlier as our top 4 things to work on.
Yeah, I think we've established that from multiple perspectives, but if anybody, again, please just call or text or email me or Kelly or Liz if there's something burning that we need to put on the front burner for this group, we will. Otherwise, have a most excellent rest of your Friday and weekend.